This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, in this video we'll learn how to perform an intracapsular extraction in a very complex case and how do we use an iris clip lens. Hi, this is Dr. Deepak Megur, and this was one of the cases which my colleague was trying to operate upon. Intraoperatively, he found that he couldn't puncture the capsule at all. The pupil was not dilating, and he was suspecting severe zonular weakness, and he stopped the case and referred it back to me. And she's an elderly lady, and the surgery is now being done under perivalvular block. And you can see the amount of phacodonosis. As I'm just tapping on the eye, the lens is moving quite vigorously. Now, this is a challenging case. Saving the bag is not going to be a very easy option, so I've decided that I'm going to sacrifice the bag. There's always going to be one concern when managing such cases. The pupil is small and rigid, and when you're trying to manipulate this large loose lens through a small pupil, there's always a risk of losing the nucleus and the nucleus dropping down into the vitreous cavity. So that has to be kept in mind. And so let's see how things are to be done. So I made a large scleral incision. It's measuring about 7.5 millimeter. It is about 1.5 millimeter posterior to the limbus with a slight frown configuration. I am fixating the globe with a posterior scleral groove which I've designed. And the sclerocorneal tunnel is now being constructed using the crescent blade. And once we have created a tunnel of about 1.5 millimeter beyond the limbus into the clear cornea, it's time to make the side port incisions. In this case, dealing with the pupil is going to be an important factor, and I need to dilate the pupil. In this case, I'm going to use iris hooks, and that's the reason I'm going to make 4 paracentesis incisions. I'm planning to use 4 iris hooks. The paracentesis incisions, they're much more posterior. Intracorneal length is very short, and they're just wide enough to allow the hooks to go inside. So this is the principle. If the incisions are made more corneal, there's always going to be tenting of the iris. The superior paracentesis, I'm going to make it posterior to the scleral groove which I've created. Time to enter the main incision. Viscoelastic is placed into the tunnel to delineate the extent of the inner lip. Once the inner lip is delineated, I'm going to use a 2.8 millimeter keratome to enter into the antechamber, and then it's going to be extended laterally on either side. And care is taken to maintain the curvilinear nature of the inner lip so that it is running at least 1 millimeter away from the limbus throughout the span of the sclerocorneal incision. And I'm going to introduce the hooks through all these 4 paracentesis incisions. The hooks are placed initially. And when all the 4 hooks are engaging the pupillary margin, they're stretched now to make the pupil wider. So time to extract the lens out. Now, how do we perform the lens extraction? So if we directly go in with 2 Sinskey hooks and try to maneuver the lens out, there could be a possibility of the capsule getting broken, and the contents of the bag can then drop into the vitreous. So the safest option always is to introduce viscoelastic behind the lens, and with the cannula itself tumble the nucleus into the antechamber. Let's see how it is done. So I'm going in with my viscoelastic cannula. It goes under the equator of the lens, goes posterior to the lens, and then I'm injecting viscoelastic as well now, and then with the cannula itself, the lens is tumbled and brought into the antechamber. So now we are in a safe zone. The OVD is placed behind and in front of the lens. Using a Sinskey hook and a vectis underneath the lens. The lens and the bag complex is held or sandwiched in between the vectis and the dialer, and then it is pulled out. At this stage, I don't think the vitreous phase is disturbed. So let me check by going in and putting diluted triamcinolone acetate. And in this case, anyway, there is no vitreous disturbance, so it is ideal. We could want to avoid vitrectomy before putting the lens if possible, when there is no vitreous prolapse. Simply because once we do vitrectomy, the eye becomes very soft, and then managing the lens inside the soft eye becomes a little bit tricky. So this is a great situation where I don't need to do vitrectomy simply because there's no vitreous prolapse, and I can just go in and enclave the lens. This is the iris clip lens, and the XL optics is the one which I'm going to use. I find they're more reliable. No financial interest though. The lens is kept on the surface of the iris now. Now before enclaving the first claw in the iris, my side port instrument, that is the cannula, has gone in first before even grabbing the lens. So because I don't want to struggle in finding the paracentesis once the lens is already in position to be enclaved. So the cannula goes in first here. Then I'm going to hold the optic of the lens. The position of the flanges of the forceps are such that they are in line with where the claw in the haptic would be. This would help me to roughly estimate the location of the claw, which is going to be underneath the iris. The haptic pushes up the iris, and then with the blunt cannula I'm going to push the iris down, and the enclavation mark appears like a dimple which I can see. But in this case it is marred by some amount of bleeding, but I just pull the lens and along with it comes the iris. This confirms that the enclavation is successful. So I come out and the hands are switched. I grab the lens with the forceps to enclave the second haptic now. Again, the second haptic goes in behind the iris and the cannula goes in and pushes the iris. And in one stroke, I can see the dimple here. And this is a clear evidence that the enclavation is good enough. So now with both the haptics enclaved into the undersurface of the iris, time to proceed to the next step. I need not perform vitrectomy in this case because the vitreous phase was intact. However, there is a lot of blood in the vitreous cavity, so I need to tackle that. And before that, I'm going to go and do an inferior peripheral iridectomy at 6 o'clock position. The reason I'm doing it at 6 o'clock is simply because the superior iris is not clearly visible because of the thick arcus here. And just because I'm having a good visibility, I'm going to go ahead and do a iridectomy in the inferior quadrant. It's usually the IA cut mode, and I'm going to use just the smallest amount of cut which is possible in my machine. That is about, say, 50 cuts per minute, just 1 or 2 cuts and you're through. Time to remove the blood which has entered the vitreous cavity. So in this case, I'm going to use the irrigation and the cutter through the main incision itself. So simply because this is easier, when we enter through the side port in this soft eye, it becomes difficult for us to negotiate the two instruments inside. So since I'm going to do a very limited amount of antivitrectomy, so in these situations, I believe that it's reasonably safe to go in through this scleral wound itself. In a couple of minutes, the blood is cleared off behind the lens. The visual axis looks very clear. So any evidence of vitreous is tackled with the cutter itself, and time to close. Now since I made a very large incision, I would be inducing some amount of gangrenous astigmatism. To counter it, I'm going to put a single tenon Allen suture at the 12 o'clock position. That's it, the case is done. The air bubble is removed, the side ports are closed, intracameral antibiotics are placed into the eye, and that's it, the case is done. These are the post-op pictures. The patient is doing reasonably well. So this is one such a complex case wherein I chose to do an intracapsular lens extraction, and for some of the younger surgeons, they would be wondering how to perform an intracapsular lens extraction in such situations. This was one such demonstration, and of course, choice always can be a scleral fixated lens or an iris clip lens. In this case, I choose iris claw lens simply because the job can be done much more faster and the results are reasonably good. So that was it. Thank you for watching and hope you found this helpful.